Okay, I think we'll go ahead and get started. I'm so thrilled this morning to have Dr. Annabelle Volgman joining us from Rush University Medical Center in Chicago, where it's very cold and snowy there, right, Dr. Volgman?
Yes, it is.
Well, we started Revel 11 over 6 years ago now. Joni and I started it with the intention of having more intimate conversations with other women about just topics that are important to our community. And health and wellness is one of the top things on our list. And so I'm just really happy to be exploring this topic of heart and brain health, because I think we can all benefit from it. And Dr. Volgman is the perfect person to be joining us this morning. So thank you so much for talking to us this morning.
Thank you so much for inviting me. It's my pleasure to be here.
Well, let's get started by what made you interested in exploring the relationship between the heart and the brain?
So it's a little personal. My husband's father and mother both had some dementia in their 80s, and I became very curious to see what was the cause of dementia, and because I didn't want to have my husband have dementia, so I wanted to prevent it with on him and me, and so I became very curious, and I started looking up what can prevent dementia. And it turns out that most of the risk factors for dementia are the same risks as cardiovascular disease. So I started becoming very curious about this, and the things that can prevent dementia are the same things that can prevent cardiovascular disease. So eating well, getting your cholesterol down, getting your blood pressure down, and decreasing your risk for heart disease was the same. Being active, all those things were very similar. And I became known to, I actually got to know some of my colleagues at Rush. Rush is a big Alzheimer's center. And I got together with one of my colleagues who is she considers herself a cardiocognitive neurologist. So she works in the Alzheimer's field, and she was also very interested in the link between heart disease and brain health. So we got together, and I told her that some of my patients were complaining that my drugs that I give them were causing them to have memory issues or dementia-like symptoms. And I said, well, I certainly wouldn't want that for my patients. And I want to make sure that they are being taken care of by the right people. So I would refer them to my colleague. Her name is Dr. Neelam Agarwal, who I tried to join us today. But my patients would either forget to go to the memory clinic, or they were uncomfortable going to the memory clinic. They didn't want to be labeled as having memory issues. So Dr. Agarwal and I discussed this, and I said, well, why don't you spend some time with us in the Rush Heart Center for Women, and you can see them in our safe area, because my patients obviously felt comfortable seeing me. And if they didn't have to go to another place, and they would just be seen by Dr. Agarwal in the Rush Heart Center for Women, that would help. And it did. It worked very well. The patients were very comfortable having their memory checked by Dr. Agarwal. And so we started the idea of making this a more formal clinic. So we have this cardiocognitive clinic. Our colleagues refer to her as well in the Rush Heart Center for Women, men and women, because we see a lot of men in the university cardiologist clinic. And so they also refer their male patients to her. But a lot of women, are seen in the Rush Heart Center for Women for their cognitive function. And thank goodness, most of them are just, part of it is just getting old. They're just anxious, under stress. And so we counsel them to decrease their stress level or figure out, if it is one medication that they feel made their memory a little worse, then we switch to a different medication. So we do a lot of different things to, and that's a long answer to your question.
No. It's perfect. It raises so many other questions for me that we're going to dive into a little bit more. Mm-hmm. But I am curious about the medications that you're referring to that contribute to some memory issues in your patients. Are those generally like blood pressure medications, or what kind of classification are those medications?
Yeah, so two main class of medications. One is the statins, which is a life-saving drug. We have a lot of data to show that it's one of the best drugs to lower the risk of heart attacks, strokes, and deaths. And stroke is a big issue, especially in women. There are more women having strokes than men, and they get it at a younger age than men. That's the one thing that women are at a disadvantage of in terms of cardiovascular disease. Men definitely have more atherosclerosis in their hearts, so they have more heart attacks, and they get heart attacks earlier than women. That's a generalization. So there are women who are young, who have family history or very high cholesterol or have diabetes for a long time, that get heart disease early on, even in their 40s, or even earlier if they have really high cholesterol. So we should always take women seriously when they're complaining of any cardiovascular symptoms, such as shortness of breath, chest pain, any sensation in their chest. The chest pain guidelines just came out, and they pointed out very clearly that women are underdiagnosed and undertreated for heart disease.
And why, you do tend to hear so much more about men and heart attacks and men and heart disease. Yes. Why is that historically? I do feel like there's a trend now that we're talking more and more about women's health and heart care. But what is the history of that? Why do you think you hear so much more about men and heart disease?
We know that men definitely get heart attacks earlier and worse than women at a younger age. And there's no doubt that men get more severe atherosclerosis, which is the plaque-forming disease that causes heart attacks and strokes. So men get it earlier. We don't know why that is, but we think that it might be the protection of estrogen, because after menopause, which may be an age thing as well, but after menopause, women definitely get more heart attacks after the age of menopause, like starting in their 50s. But historically, there were about 30,000 more men dying of cardiovascular disease in the United States in the 1970s. And then by the Framingham Heart Study in the 1970s reported that the risk factors for heart attacks were smoking, high cholesterol, high blood pressure, family history. And so we told the men, we were taught in medical school, I was educated in the 1980s, and we were told heart disease is a man's disease. So we helped the men prevent heart disease, but we didn't help the women because we were told it. So by 1984, since the men were treated more aggressively, we started treating women with high cholesterol, giving them hormone replacement therapy. That was a treatment because there were some studies that showed that hormone replacement therapy did lower the LDL cholesterol. So we thought, well, great, women love hormone replacement therapy. Treats their hot flashes, makes them feel better, makes them more feminine. And so we gave them hormone replacement therapy to treat their high cholesterol. And by 1984, we started to see a much higher increase in mortality in women from cardiovascular disease until 2000. So by the year 2000, there were 70,000 more women dying of cardiovascular disease than men. And that's when the AHA, the NIH, and all the national health organizations started saying, hey, maybe we should pay attention to the women who are dying of heart disease and we don't really know what we're doing. And that's when the Women's Health Initiative study that was started by the NIH, who was led by a woman, and she gave like $6 billion towards studying women's health. Any, from osteoporosis to breast cancer, to ovarian cancer, to heart disease and strokes. So it was really very informative because it was randomized controlled studies, finally, in women, not these observational studies. So that's a gold standard in scientific medicine, is randomized controlled studies to really know whether something causes something else. And we found that hormone replacement therapy in older women, so these were women usually in their 60s, so 10 years post-menopause, had more strokes, little more heart attacks, more breast cancer when they were given hormone replacement therapy. It did improve colon cancer and osteoporosis, but that was not enough, of course, to decrease the in terms of risk and benefit ratio. It was considered not advisable to give women hormone replacement therapy in their 60s. And we can talk more about that.
Okay, yeah. So yeah, I have lots of questions about that.
I know.
So yeah, let's finish up this hormone replacement conversation because it is such an important one.
It is.
But wasn't that study, a lot of those women were starting HRT in their 60s versus at menopause. And so what do you think is a good approach with hormone replacement therapy for women just at menopause? Because there are a lot of other benefits, correct?
Yes, we have been studying this since 2000. So it's been 23 years. And for a long time, probably for the first decade after that came out, we were so reluctant as physicians, and the obstetricians and gynecologists were so reluctant to give women hormone replacement therapy because of that data. And then as we continued to do the studies, and there were some other studies that were being done in younger women, it turns out that if the woman who is in her 50s and just starting menopause is very symptomatic and they have no heart disease, they have no evidence of atherosclerosis, it actually benefits them to be on hormone replacement therapy in terms of heart disease. However, in women at any age, if they've already had a heart attack or if they've already had a stroke, they should not be given hormone replacement therapy to lower the risk of heart disease or strokes, because they have a much higher risk. They're a different population of women. So I hope that's clear.
I think it is. And if it's not for people and you have questions, just please put your specific question in the chat area. I'd love to back up a little bit and kind of go through the basics of like symptoms and what tests that we should be having.
So there's a lot of talk about women have different symptoms than men, and some of them do, but for the most part, if a woman is having a heart attack, their symptoms are going to be very similar to men's symptoms. So women with heart attacks don't say pain, they say other words. They hate to use pain. That's what I've noticed. And so we now will say any sensation in the chest that is uncomfortable, that is different, that is sudden, consider that as a heart attack until proven otherwise. And so if there is a sudden change in the way you feel, especially with exercise or, emotional stress, and it is not going away, after about 10 minutes, you should call 911. So that you can be taken to the emergency room, because nowadays we do 12 lead EKGs and we can diagnose a heart attack before you even get to the emergency room, so that the cath lab is ready to take you to the catheterization lab and open up that artery that is closed up, and stents can open that artery. And that is the only situation where stents actually save lives. Stents can improve symptoms, but in stable patients, it has never been proven to be better than medical therapy in terms of saving lives. It can improve symptoms. So we don't want to do asymptomatic patients.
Like, how about like the tingling in your left arm and symptoms like that? What else should we be watching out for?
Besides that sensation in your chest, most women will complain of shortness of breath. Men do too, but shortness of breath, just not feeling well. Some of the symptoms that lead to heart attacks, they're called stable or unstable angina. So when you start having these symptoms, don't wait for the heart attack to happen. You should start telling your doctor that you're having these symptoms and you want to get checked up. And women need to be much more aggressive in asking for those tests, because doctors don't think of heart disease in women, despite the fact that we've been talking about this for 23 years. So women.
Okay, so what are some of those symptoms that would encourage us to ask our doctor?
So any change in the way you feel when you're exercising, you need to know your body. So if you can run 5 miles, and that's great. But if you start having shortness of breath before you usually, than usual, more than usual, any change in the way you feel, if it's, if you're a great runner, you could still have heart disease, because the heart can develop collaterals and build ways to feed the heart. So any change in your symptoms, you should really be alert, especially if you have risk factors. And we can talk about those risk factors as well.
Okay, then let's talk about the tests that we should all be getting, and like at what age should we start getting tests?
Absolutely. First of all, everyone should know their blood pressure and should be monitoring their blood pressure. And even before that, every woman should know their risk factors, such as did they have any adverse pregnancy outcomes? And this is a new risk factor that we are trying to teach doctors about, because besides the usual high blood pressure, high cholesterol, diabetes, smoking, family history, we are supposed to be asking every woman if they had any adverse pregnancy outcomes, including preeclampsia, high blood pressure during pregnancy, gestational diabetes or diabetes during pregnancy. Premature birth is a risk factor for both the baby and the mother. This is still in the works, but even late birth, so not premature, but if the baby is due later than it's supposed to be, that's also becoming a risk factor. So these questions need to be asked. And if your doctor doesn't ask you these questions, volunteer them, please. If you develop preeclampsia or gestational diabetes and gestational hypertension, you should tell your doctor that you had these problems and that you're concerned about your risk of heart disease in the future.
Okay, so get your blood pressure checked. Yes. What are the other top ones?
Lipids. So high cholesterol, and specifically total cholesterol and LDL cholesterol. If you're LDL, and we don't go by just the numbers anymore, we do the total risk of a patient, okay? So if your but we still give some general numbers. So if your total cholesterol is over 200 or your LDL is over 100, you should consider lifestyle changes to lower that cholesterol. And these usually decrease your animal product intake. So decrease any food that you eat that comes from an animal. So
including
dairy,
chicken?
Yes, including poultry, including fish, can raise your cholesterol.
Interesting.
It's good for omega-3 fatty acids, which is a little protective, but if you are trying to lower your cholesterol, any kind of animal product will raise your cholesterol.
Okay, so just clarification, because
yes.
I have high cholesterol and I've been eating a lot of salmon thinking that the omega-3s will be helpful.
Yes.
Not a good idea?
So remember I said it's not just the numbers. We need to take up the whole picture. So I know you're curious about what risk scores we should be using to figure out the risk of any person, man or woman. So we now use what we call the atherosclerotic cardiovascular disease risk score, or ASCVD risk. And
is this common? Like
yes. Yeah, you can do it yourself. Just Google ASCVD risk.
CV as in Victor?
Yeah, CVD, cardiovascular disease, CVD. So A as in apple, S as in Sam, C as in cat, V as in Victor, D as in a dog, ASCVD risk score.
Okay.
Every adult should know the risk. But to get that risk, yeah, there you go. Thank you. It's in the chat box. If you want to know your risk, you need to know what your blood pressure, whether you have hypertension. You need to know what your blood pressure is on the average. Of course, you need to know your age and your sex.
Okay. We can all take a deep breath while Dr. Volgman comes back. Oh, just a bad connection for a second.
Did you lose me? Okay, so you'll see what you need to know. But what you actually need to know is your total cholesterol and your HDL cholesterol, which will, when you get a lipid panel, you should have all that. So, so the fact that your HDL, I mean, Monica, I hope your HDL is high, and maybe that's why your total cholesterol is high, but that is protective. But if your LDL is really high, that HDL is not as protective. So you need to know all of this.
Okay.
So every person who wants to know the risk score, you can do it yourself. And then what was if your risk,
sorry, you're going out again. Maybe you should write some of these important ones down in the chat.
Yours is more than 11. You know what? Maybe what I'll do is use my phone for verbal, just so that okay, we can do that. I can talk also while you ask me more questions.
Okay. I would like to know, beyond the standard tests that like our primary care docs would order for us, what should we be asking for? Like, I know I recently had a calcium, I think it's called a calcium test. Yeah. Is that a good one to be requesting from our doctors, or do you have other recommendations?
Yeah. So in the guidelines, in the doctor's guidelines for how to treat people or how to prevent heart disease, we are supposed to figure out your risk score. So if it's greater than 7.5% in the next 10 years of having a heart attack, stroke, or death, we should recommend statins to lower that risk, not to treat the cholesterol, but to lower the risk of having a heart attack, stroke, or death. And that's when a lot of my patients are willing to take that, the statins, because they don't want to take it to lower their cholesterol, but they're willing to take it to lower the risk. It's really interesting. So
a lot of my friends are so reluctant to get on a statin because they hear these horrible side effects of like, muscle aches and all that good stuff.
Of course.
How common is that?
It's actually not as common as you think. But let me just finish my thought about the risk score. So between 5% and 7.5% is like, you're still at a little bit of risk. But if you have a family history, you may consider doing a coronary artery calcium score. So it's a CAC score or CAC score. It's a very simple test. It costs less than $100. You don't have to have your doctor prescribe it for you. A lot of hospitals will offer it as a screening test. Just
so
like
we would be asking for a CAC score test?
Yep, okay. A CAC score. There's very little radiation, so no need to be worried about the risk of radiation for lung cancer or breast cancer. It's a very quick test. You don't even have to take off your clothes. You just go in there. They scan you for a few seconds, and you get a CAC score. If your CAC score is greater than or equal to 100, we would recommend that you start on statins, because that means you're already developing plaque in your arteries, in your heart arteries, and your risk exponentially goes up the higher the score is.
Okay, so that's a great one.
If your score is less than 100, that means that you are developing plaque, but it's not high enough that you need to take statins, but it should be a call to action that you are developing plaque, and you should lower your risk by lowering your blood pressure, lowering your cholesterol, increasing your physical activity, all those things that prevent heart disease.
Okay, so maybe we should transition a little bit to lifestyle changes. So what is a
normal calcium score is 0.
Oh, okay.
You want it to be 0.
Yeah, I wish mine was 0. It's not.
Uh-oh.
Okay, so let's transition to lifestyle changes that we can all make. So let's start with the diet thing. So we just talked about how we should avoid animal products. Mm-hmm. Do you favor one diet over the other, like, the Mediterranean diet or MIND diet?
Yeah. So unfortunately, we started recommending low-fat diet a long time ago in the 1980s and 90s, and probably a big mistake. What we should have been recommending, and we know now, is eating a lot of monosaturated fats, such as olive oil and avocados, and they have a lot of calories, so we have to be mindful of that. But those are the good fats. Unfortunately, the low-fat diet did not decrease cardiovascular deaths. What has been proven to decrease cardiovascular deaths is the Mediterranean diet, which is having a lot of monosaturated fats. There is some animal products in there, but when you mix it with healthy vegetables, fresh vegetables such as tomatoes and leafy green vegetables, and you eat that diet with people who love you, it seems to lower your risk. So don't eat the Mediterranean diet with people who don't love you.
So that leads to the question of the lifestyle component around stress.
Yes.
And so is that, I assume that that's a very important part of this.
Yes, it is. Stress leads to all kinds of bad things in our bodies. It leads to metabolic syndrome because people eat different things when they're under stress, and it leads to what we call metabolic syndrome, where you have abdominal obesity, your triglycerides go up, your HDL goes down, because most people who are under a lot of stress don't exercise as much. They, their blood pressures go up, so it increases the risk.
Real story around red wine and alcohol in general. Our Revel 11 group has been doing like dry January, and now we're doing moderation management. What do you feel about alcohol?
Okay, so lots of different studies have been done on alcohol. So I just want to emphasize that there are different kinds of heart disease. Okay, so what we've been talking about is atherosclerotic cardiovascular disease. So plaque buildup in the heart, in the carotid arteries, in the brain, in the kidneys, in the legs. If you have that, those people who were studied who have that, and if they drink a little bit of alcohol, a little bit of wine, there seems to be some benefit. Okay, they were not randomized controlled studies. These are observational studies, so no gold standard studies. So these are observational studies. So we could be completely wrong. It may be that people who drink alcohol and who have this disease also have better lifestyle, or they are richer, and so they have better health care. So that's the problem with observational studies. So there's an association in people who drink a little wine. And so for women, it's less than one glass of wine. And for men, less than 2 glasses of wine. That seems to, it may be that the HDL goes up with alcohol. We know that that is true in some people. So that may be the benefit, but it could also be, a lot of social issues that go along with that. We know
when you say
that
wine, does that mean red or white?
So some of the studies are using red wine, some are just any alcohol. But we know that going beyond drinking that 1 glass for women and 2 glasses for men, that's the use of alcohol is associated with an increased risk of an arrhythmia called atrial fibrillation. So this is a different heart disease. So we're not talking about atherosclerotic cardiovascular disease anymore. We're talking about atrial fibrillation. So a different arrhythmia, a different disease, but it's an arrhythmia of the heart. It causes atrial fibrillation, and that can lead to strokes and heart failure. So that's the problem with wine. If you drink a little bit, you're good, but if you drink too much, then your risk of atrial fibrillation goes up. So if you can go, if you can manage that boundary, that would be okay. But most people, they overdrink. Once they start drinking, they drink more and more. It's fun. People don't like when I talk about this, but remember,
Nobody does, right?
Yeah, remember that there's also a risk of breast cancer with alcohol use. So, there's that problem too.
Yes. Exercise.
Yeah.
What type of exercise is beneficial? Is all exercise, or should it be cardio?
Yeah. So, cardio exercise like running or walking, I just recommend walking because it does not usually lead to injuries, such as knee problems, joint problems. Walking is a great form of exercise. So what we've learned is 150 minutes of exercise a week would be beneficial. So that means 30 minutes, 5 to 6 times a week is perfect. If you can
manage. Was that 115?
150. 150, 150 minutes a week is what has been recommended to decrease the risk of heart disease. Whether it's swimming, you're not going to lose as many calories with swimming, but it's a great form of exercise. Getting your heart rate up. One of the benefits of exercise, besides, decreasing your blood pressure, increasing your HDL cholesterol, which is a good cholesterol, is that makes you feel better and just great It's a great way to make your body know how to raise the heart rate and how to lower the heart rate, so that when you're under a tremendous amount of stress, your body knows not to freak out when your heart rate goes up, and it knows how to lower it as well. And that's why a person is fit when their heart rates can go up, but they can also go down pretty quickly. If the person maintains a fast heart rate after exercise, that's a sign that the person is not as healthy.
How about strength training?
Strength training is, it doesn't have the cardiovascular benefits as much, but if it makes you stronger and makes you better at exercising, then it's fine.
Okay. But does that contribute to the 150 minutes, or should that really be a form of exercise that raises your heart rate? Yeah, it's a faster heart rate that would be good towards the 150 minutes a week. Okay. And I noticed in the chat area, there was a question about, is the CAC test different than a DEXA scan? And I'm still confused. Is the CAC test also the same as the calcium CT scan?
Yeah. So the CAC score stands for coronary artery calcium.
Okay.
The DEXA scan is for bone health. So totally different. And the CAC score, or the CAC scan, is the same as the CT calcium.
Okay.
Yeah.
Okay. Was that list of tests complete? Were there any other tests that you recommend that we get, either for stroke, brain health, anything?
So what I have learned, after we're celebrating our 20th year anniversary of the Rush Heart Center for Women. So I've been taking care of thousands of women, and I've learned a lot from taking care of all these women. What I've learned is that a lot of young women will go to the doctor and they have family history of heart disease, and they'll just get their cholesterol checked, their blood pressure checked, and nothing else. And they'll be given some information that their risk is low. The ASCVD risk score decreases the risk for women and decreases the risk for young people. So it doesn't take into account the family history. So if you're a woman with a family history of premature coronary artery disease, which is defined as men having a heart attack or stroke in their 40s, women having a heart attack or stroke in their 50s. If you have that risk, you need further testing. You should not be considered as everybody else. You should have an advanced lipid panel, which would include lipoprotein A. Okay, so for those people, they should really be getting lipoprotein A determination. And don't just go to your primary care physician, and don't go to a general cardiologist. Make sure you go to a preventive cardiologist who would know about this, because sometimes doctors don't know about what lipoprotein A is, and they'll look at you like, don't worry about it. You're young. Even though you just told them that you have this terrible family history, they'll pacify you into thinking that you're fine because they don't know about it. And so they ignore that question, and that's really a disservice to women.
So lipoprotein A is a test. Yeah. Okay.
It is. They can get that measured. If it's very high, you need to be treated aggressively, because lipoprotein A is a risk factor not only for developing the plaque in the arteries of your heart and your brain, all of your body, but it can also form blood clots. You're at risk for forming blood clots. And it's also associated with forming premature aortic stenosis. So lots of repercussions when you have an elevated lipoprotein A. And it's finally being addressed by the pharmaceutical companies, because they have these new biologics that can finally lower the lipoprotein A by 70 to 80%. For years, we tried to lower lipoprotein A with niacin. And unfortunately, niacin it's a drug that can lower the triglycerides, and it can reduce the lipoprotein A by 30%, but it was not enough to lower the risk. So we now are studying drugs. So we are actually actively studying patients with elevated lipoprotein A. And we're going to see how giving this drug for 5 years to thousands of people, if that drug can lower the risk of heart disease. It's an ongoing study. We will know probably in the next 3 years whether that drug can lower the risk.
And do you recommend that we start with our primary care physician to ask for a lipoprotein A test?
If you feel that you have a good relationship with your physician, your primary care physician, you can, and just say, I know, there's no cure for this yet, but there are studies that are being done right now. So educate your doctor, in a non-threatening way, because you want to have a good relationship with your doctor, right? And you want to teach them as, doctors don't know everything. So, if you can teach them in a non-threatening way that, you heard this from a cardiologist and you have family history, you would like to get this checked, because even though there's no cure for it, you can lower your risk by starting an aspirin, a baby aspirin. People benefit from baby aspirin. Some people benefit from a baby aspirin, some people don't. People with lipoprotein A, maybe the group of people who could benefit from this. It really depends on how high the level is, but if it's very elevated, the LDL cholesterol should be lowered using a statin. So the benefit for women is that if their LDL is low and their lipoprotein A is high, it doesn't seem to be as bad. But for men, even if their LDL is low, if they have lipoprotein A that's elevated, it's a risk for them. So if your husbands have family history, if your husbands or loved ones that are males have a family history of heart disease, have them get their lipoprotein A checked, because they need to be treated aggressively.
So only if you have a family history should you request that test?
Yeah.
Okay.
Yeah.
Okay, great. We had another question about the benefits of some lifestyle activities for cognitive health, which might be the same for heart health. Do you have recommendations?
Well, as we speak, we are actively studying 250 women and randomizing them. So we're doing a randomized control study. We've got an NIH grant to study 250 women. 60% of them came from the Rush Heart Center for Women over the age of 65, and we randomized them to physical activity, doing puzzles and cognitive games, or doing both versus not doing these things. So we will know in 2 years whether we know for sure that physical activity can decrease dementia or cognitive dysfunction. But for now, we know that exercise, eating healthy, and sleeping well can decrease cognitive dysfunction. So that's what we recommend.
Okay, and I know we're running out of time, but I would love to touch on if there are any specific things we should be aware of related to stroke. Like, is the risk of stroke pretty much in line with the risk of general heart disease?
Yes, except that women tend to get more strokes than men, and they get them at an earlier age. So
like what age?
At an earlier age. So anyone who's over 50, the risk factors for strokes are similar. Big risk factor, especially in women, is high blood pressure. please get your blood pressure treated. If your blood pressure is frequently above 130/80, and you have other risk factors such as diabetes or high cholesterol, you should be aggressively treated. If you don't have other risk factors, then we can be more lenient and start treating with drugs if your blood pressure is over 140/90. But for the most part, you want your blood pressure to be less than 120/80. So however you get there, with exercise, with losing weight, with changing your diet, decreasing your salt intake, get your blood pressure to less than 120/80. Because that is a big risk factor for stroke.
Okay. And how about cholesterol and stroke? Are those two related?
Yes. So high cholesterol can form the carotid, so they can form the plaque in the carotid arteries and in the brain. And strokes happen when there is a complete lack of blood flow to the brain. Just like a heart attack is complete lack of blood flow to the muscles of the heart. In the brain, it's in, a stroke is in the brain. So if a plaque ruptures in the carotid arteries or in your brain arteries, then it can completely block the flow of blood to the area that it's feeding. That's a stroke. So that's why it could be so many different things. It could be, your vision, it could be facial droop or arm weakness. A good thing to remember is the acronym FACE. So facial droop, arm weakness or leg weakness. Let me see, what is the, oh no, I'm sorry, it's FAST. So FAST, I can't even remember it. FAST. So facial droop, arm or leg weakness. S is speech. People, start slurring their speech. I've had people diagnose their moms having strokes when they're talking on the phone and all of a sudden she's slurring her speech. Call 911, get them to a stroke center. Because at least in Chicago and major cities, if somebody's having a stroke, they go to a stroke center and they can pull out that plaque from the brain and prevent that stroke. And then T is time to call 911. So FAST, facial droop or facial, strange things happening to their face, arm or leg weakness or numbness. S is speech. T is time to call 911.
Let's talk about blood sugar really quickly before we end. And a lot of friends are saying that they're pre-diabetic.
Yeah.
How does that relate to heart disease?
I'm so glad you asked that question because diabetes is a huge risk factor that affects women more than men. So men and women get diabetes, okay? No discrimination, who can get diabetes? But when a woman gets diabetes, they have a higher risk of having cardiovascular events. So women with diabetes get more heart attacks, more strokes than men with diabetes. And I just gave a talk to the International Diabetes Federation in Portugal this past December. And they asked me to speak about cardiovascular disease in women with diabetes. And what I learned and what I've shared with the diabetes doctors is that when women get diagnosed with diabetes, they are diagnosed 2 years later than men with the same weight and same metabolic problems. So we're working on trying to figure out whether this pre-diabetes, we call it pre-diabetes, hemoglobin A1C is still not as high as it should be to start treating them with drugs. We may be missing those 2 years of building plaque in the arteries of the heart and the brain. So we may need to give that diagnosis a little bit earlier in women to protect them better. They're not going to be happy that, they're going to be labeled with diabetes 2 years earlier, but, maybe we can prevent their heart attacks and strokes. So we're working on that as we speak, actually.
Do you mind just going through the rundown of the most important things? Like, when is it irresponsible to be not taking medications when you're trying to resolve your issues naturally, like through lifestyle changes? So both for blood sugar and for cholesterol and for blood pressure.
Yeah, it's such a personal thing. We need, as physicians, we need to respect our patients' wishes, and we're trying to be sensitive to our patients' wishes. But I think patients need to be realistic. We do all of these studies, and we need to help our patients. So when you come to me as a patient to be helped, it's a give and take, right? Some of my patients will say, I want to know my risk, but I want to try lifestyle changes. I don't want to do drugs yet. So it's my responsibility to help that patient get to that place where we are preventing heart attacks and strokes. But I will give a patient 3 to 6 months, or however long she wants, to decide whether she can do it with lifestyle changes. So if a patient is, let's say, has a risk of 15% in the next 10 years that she's going to have a heart attack or stroke, I'm going to tell that patient, your risk is too high, and studies show that you would really benefit from statins or blood pressure medications. And if she still doesn't want to take medications, I'll give her 3 months to prove to herself, not to me, but to herself, that she can be safe with those lifestyle changes. And if that risk is still as high as it was and she's not making any movement, that's when I start talking about, you really are putting yourself at risk. I don't want to make people more anxious than they already are, because a lot of women who come to me are very anxious. But I eventually will convince them that we can lower their risk a lot with lowering their blood pressure and their cholesterol, and treating their diabetes to lower the risk of heart attacks and strokes and death.
Okay. So it sounds like it's teamwork between you and your doctor.
Absolutely.
To figure out your personal
it's a partnership.
approach. Yeah,
it's a partnership. And also teamwork is a good term, because I do work with my nutritionist. I am not an expert in nutrition. I have a cardiologist who works in the Rush Heart Center for Women, who treats obesity, and she's board certified in obesity medicine. So she uses the new diabetes drugs that can decrease their weight. It's so popular that we can't even get it, because it's so popular, because it is effective in decreasing their weight.
And side effects are pretty minimal.
Yeah.
Good to know.
Yeah.
Well, we are out of time. This has been such an informative session. I really appreciate it, Dr. Volgman.
Oh, it's my pleasure. I'd be happy to, answer a few more questions if there are any. We still have, I think we have 3 minutes.
Yeah, please. Anyone, you can put your questions in the chat area, or you can email me with specific questions and I can follow up with Dr. Volgman. We will have a recording of this on our website at revel11.com that you can check out starting tomorrow. There is a question about Seattle area. Do you see that in the chat?
I noticed that. So, I'm happy to take care of people who live near Chicago. I do have some patients that come, from all over the country, but I would recommend that they find out a center for women. There are a lot of female cardiologists who are interested in helping women. So look for a heart center for women that is near you. You will find that women who are sensitive to women's issues will get treated better.
I know of a heart center that is supposed to be very progressive, and they do focus on women as well as men, but in Spokane. So if you're willing to travel, there is a great one there, and feel free to follow up with me if you want more information. How about this question that we have in the chat about diet and sustainability? And I have a friend right now dealing with this who was diagnosed with diabetes and trying to figure out diet without ruining their life as far as lifestyle changes and not being able to eat anything. So how do you modify your diet?
Yeah, so my colleague, Dr. Kim Williams, is a huge proponent of plant-based diet. He was my mentor. He's our chief of cardiology at Rush, who just became the chair of medicine at the University of Louisville. So his name is Kim Williams, and he is a huge proponent of plant-based diet. It definitely lowers your cholesterol. So would I recommend it? Yes, I would recommend it. And Dr. Williams is passionate about this. If you are happy with it, if you can be happy not eating animal products, then go for it because it is healthy. But if you're eating unhealthy, not plant-based, an unhealthy plant-based diet, such as potato chips or, fast food stuff, then that's not healthy. That's not gonna help you. So go with your parameters, go with your blood pressure, go with your cholesterol. That's how you base your health, is calculating your risk score with that ASCVD risk score, and follow that. Figure out what it is that's making it high and try to lower it.
Mm-hmm. Well,
so a diet that you can live with and make you happy, I think is the best diet that can lower your risk is the best.
Yeah, the sustainability approach of how do I maintain this over time and not just like a fad. But I did want to mention next Friday, we are meeting with the author of this, Stephanie Sachs, about What the Fork Are You Eating, which I love this title. And her approach is so no nonsense, obviously, based on the title. But she's meeting with us next Friday. So I hope you join us, and you can find out more information on revel11.com and sign up there. So again, Dr. Volgman, thank you so much for your time and expertise. We really enjoyed this session, and I'm going to go make myself a healthy breakfast that's plant-based.
That's great. Well, thank you, Monica, and thank you all for being here.
Yeah, hope everyone has a great day and a great weekend. Talk to you.